Okay, good morning everyone. Thank you very much for attending the workshop. So here we're going to present to you the methods of measurement that we used in the screening, and Andreas is also using these methods when he's looking at his management of the acute groin pain patients, and is able to use his measurements to assess the progress of the patient, because we have established some valid and reliable tests that we can repeat confidently, that we're testing the same thing each time, and therefore we know the error measurements, and therefore we can see whether the patient is improving over time. When we were deciding on the methods of measurement to use for the screening and also for Andreas' study, we did quite an extensive literature search, and as anyone who's looked at the literature around measurements in the hip, there's many different methods presented in the literature. Some have intra-tester and inter-tester reliability established, some don't. Particularly with the methods of measurement of strength, they vary considerably in terms of position that people choose, the type of instrument that people choose to measure, and also the method of measurement, whether you're testing an isometric or an eccentric test. So when we were making decisions, there was a number of factors that we took into consideration. One was, does this test have good intra and inter-tester reliability? Does it have validity? Has it been demonstrated to be predictive of injury? And that's one of the reasons why we chose eccentric over isometric tests, because eccentric testing of the hip joint has been shown to be more predictive of injury than isometric testing. And then other factors such as speed and ease of conducting the test. So it was very important to us that we weren't spending a lot of time on each test, because the footballers, as I mentioned yesterday, had a very long day, and we wanted to try to make the screening process as efficient as possible for them. The other thing was, we were only ever going to be able to test with one physiotherapist at a time, so we needed to choose tests that a single operator could do effectively without compromising the reliability or the accuracy of the test. So that's how we made our decision in terms of the methods used and the instruments used as well. And there was a very nice review paper, recent review paper by Dobson, that showed that you have equal confidence and reliability in instruments such as goniometer, digital inclinometer, or fluorometer, which is the fluid-filled inclinometer. So that was quite nice for us. We could choose which instrument suited us. Okay, so
we chose to use these digital inclinometers, and one of the main reasons for that is that you get an exact measure, so you're not influencing your measure by the way you're holding a goniometer or the way you're looking. So all you're actually doing is feeling the end range of motion. You push a button and then you can look what you pushed. So that's a more valid way of measuring in our opinion.
We're not going to demonstrate internal rotation and hip flexion, because you saw it in the picture yesterday in my slides, and it's just done with the goniometer, and we feel that everyone has great experience with that method of measurement. So just for time, we're going to show the other tests.
We'll start with a combined measure, which is a bent knee fallout, to measure adducted tone. So we get the patient down here. We'll give him about 45 degrees of hip flexion here. And so we get the knees and together here and the feet together, and slowly take the knees out to the side. Get the heels together again, make sure they're the same distance, and do a gentle overpressure here to make sure that he's fully relaxed in the muscles around here. Then what we're measuring the hip of the head of the fibula out here on the side, and because he has a bit long legs and a narrow bed, we're going to use something to extend the bed here, so we get a straight measure out here that's easier to do. Put the tape measure here. I'll come over to the other side as well. And then we get a measure here that we're going to do to the closest 0.5 centimeters. So on this side we get 12 centimeters. And on the other side here, the head of the fibula, your palpation skills here, and then you can go down here and you can see that that's 10 centimeters, which when you look at it you might see a small difference, but not very big. But 12 and 10, at least it gives us a difference of 2 centimeters from the ground, so we can it's indicated that he might have a bigger muscle tone on the left side.
So this is a beautiful test because it is very much a combined test. So it's looking at abduction range, it's a function of abduction range, external rotation range and adductor tone. And it'll be really interesting to see how well the measurements on this test are predictive of future injury. It's certainly being used that way clinically in Australia, and it's very commonly used as a test to measure how well an athlete is returning from their sport and from their injury back to their sport. So it's one of the tests that's used to determine whether an athlete can be reloaded, because it's thought to be an indicator of adductor tone, and adductor tone be an indicator of response to load. So if you're loading an athlete and then wanting to see if they've coped with that loading before increasing the loading again, this test is one of the things that's used along with some of the other pain provocation tests.
This is also one of the reasons why we're using it for the acute injuries. When they get in here, we'll follow them regularly and measure their
Just one comment about using the dynamometer, so I stay in that same position. When the test is described in the literature and the reliability, which was very high, was published, it was described as bringing the rigid tape measure to the line of the bed. So obviously we need to be in the line of the bed, but as you can see quite clearly on these beds, it's curved. So do we take it from here? Do we take it from here? Do we take it from here? So what we decided to use was a more rigid strut, so we could be confident that we had a definite line that we could compare the rigid tape measure to. So I'd highly recommend that, because you know, there's different levels of cushioning depending on how flattened your bed is with the use from athletes. So I think having something rigid like this, we use the Dynamometer, is important to validate your measure.
Right, next measure is the internal rotation. As mentioned, this one we're going to do in prone. So if you get on your stomach and a little bit further down. Yep, perfect. And again, we're going to use the inclinometers here, digital ones. And here we wanted to test where we had the hip in 0 degrees, or as close to neutral as possible. So that's why we put them in prone, compared to the other measure where you put the hip in 90 degrees flexion.
And I didn't show this data yesterday, but when we had a look at that preliminary data that we've collected, the measure in extension, so the prone internal rotation measure, when we looked at the correlation with the hip flexion internal rotation, it was around about 0.5, so about 0.48, which means that 25% of the variability of one of the measures explains the variability in the other measure. So it means a lot of the time it doesn't explain the variability. So I think as clinicians we are probably comfortable with this understanding that perhaps hip flexion and internal rotation, thank you, is measuring a different thing than hip internal rotation in extension. So it was important to us that we measure internal rotation in both positions, and it appears from our data that that was a good decision. Okay? And if you know, the other argument that will always be presented is the athletes are generally performing in extension rather than in full 90 degrees of hip flexion, unless you're a particularly good footballer that does his flip kicks in 90 degrees.
So when we're starting the measurements, we're always starting about with marking up the patients, and one of the marks that we use is a mark 8 centimeters proximal to the most prominent point of the lateral malleolus and around here. This is also the mark that we're going to use for.
Yeah, so we did a mark, I think I described it as a tattoo screening yesterday, where we used this permanent marker from the lateral side all the way around to the medial side, and so we had a nice reproducible point on the medial aspect of the tibia. Okay, and with this test, it is important to try and have the knees held together, and very commonly the athletes will spread their knees apart as we're doing the test. So try to get them to hold their knees together. Place the digital inclinometers on those medial points and bring them gently out into internal rotation. Relax. And the same thing as we talked about with the bent knee fallout, this gentle overpressure. So you're not reefing them to full end of range, but just where their tone stops and we get that little bit of a block. And the important thing with this test is to try to make sure that the issue tuberosities are level, because it's very easy to have an abnormal measure because the pelvis is not level. And in the study that we got this test from, they used a set square over the pelvis to ensure that that was flat. And we chose not to use that because we were confident in this position that we could eyeball that very well. And the use of a set square would have just created an extra piece of equipment and an extra bit of time, which we were not keen to do with our screening. So, as with all of these tests, choose the best that you have given the circumstances. Okay, and then you just press hold, and you automatically get 2 measures, and then reset after each test. In our reliability trial, we looked at measures of the range of motion with 3 repeated measures. And what we found was that it didn't add any value to the reliability if you did the 3rd measure. It made a difference whether you did 2 versus 1 measure, but not a greater reliability if you took the average of 3 measures. So we recommend using 2 measures for the range of motion measures.
For the range of motion, taking the average and not the highest or lowest. So the average of the total. Yep. So next up, on the other side. Next up, we're looking to find a measure for the straight abduction movement. A lot of the times when people have described this measure, they're either using a goniometer, and a lot of the times they're using 2 testers, so one holding the goniometer, one reading, and so on. So we wanted to have something that we could use as a single operator, and we wanted to use a digital inclinometer as well, so we're not influenced by that. So if we get Robajan out here to me.
It's very important to have the athlete in a straight line level with the bed, so that you can be confident that your movement is in that plane of motion.
So we get the lower leg up in 90 degrees hip flexion and 90 degrees knee flexion as well, and that will stabilize the pelvic here, the pelvis. We get his shoulder back, so he's in a straight line here, and he can use the hand to hold on here to stabilize a little bit. Then I lift his upper leg, the leg that you're testing, and I do it from the medial side, so he's relaxed here, and he can vary in the amount of knee flexion that he has. But so you're just supporting with your lower arm, and then when he feels comfortable, that's the position that we use. And then from the markup, we have a markup point here, 5 centimeters proximal to the patella, that we did when he was lying on his back. And then we're ensuring that he's in 0 degrees hip extension, or in the hip in general. So the straight line here, and then you just move the leg up here. And if it's a big guy and a small girl testing, you just use your back to lift up here. So when you feel that now he's fully relaxed, and you go up to the end range here, you just put the inclinometer on the mark, and then you get the measure, and you do that twice as well. So here we have a more straight hip abduction movement, pelvis stable, and end range. So from our reliability study, we showed that the standard error measurement is within 3 degrees, so it's fairly accurate, or pretty good actually. So
we had very good ICCs for this test as well. So one thing that we liked about this test, first of all, the fact that we could use the instrument and it showed to have great accuracy and reliability, but we're measuring hip abduction without taking into account the soft tissues around the knee. So we felt that perhaps this is a more specific to the hip joint, and it's different from how hip abduction has been tested in the past. And if you remember the slide by I can't remember which speaker, Christian and someone else also, that there is conflicting results about whether abduction range of motion is predictive of injury, and perhaps that is because of the method of measurement. So we'll know more from the study that we're conducting here in Aspetar about this particular measure and whether it is predictive of injury. Okay, so now we go on to the strength measures that we did. Stay there. We chose to use the Power Track, which, as you saw in some of the presentations yesterday, is being more widely used throughout the world. It's fairly portable and or very portable and easy to use device, and relatively inexpensive as well. So in clinics in Australia, there's a lot of people purchasing the Power Track.
You can use different dynamometers. What we like about this one is that it's you're able to have it in your hand, so you can kind of correct the patient as you're pushing down as well. So you have a controlled feeling of the patient instead of other measures using two hands.
And just like with the previous test, it's very important to ensure that the athlete has a fully straight body and leg, so that you can be confident that you're actually testing abduction strength. It's essential that we have the rotation in neutral, so toes pointed forward, however you want to describe that. Make sure the pelvis is also forward, make sure they're not in too much flexion or extension, but directly in line. And we spent a long time with our athletes trying to make sure that they felt this position and could maintain that position. The other thing that's really essential is that the knee is kept straight. Okay, you need to use the quads to lock out the knee, because if they start bending the knee and moving into this position, we're no longer testing the same muscle group, are we? We're no longer doing the same test. So knee straight, toes pointed forward. We did we did a practice test so that we could check the technique, but also to get rid of that first contraction, and then did 3 maximal contractions and took the best of the 3. That was the method that we used. With each test, we did a 3-second isometric and then a 2-second eccentric contraction. So I'll just demonstrate that for you now. So lock your knee for me. And we had our mark here. Go ahead. Push, 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 push. So you could see there, Robert Young's done this test lots of times, but you could see that he forgot to keep his knee straight. And he's trying to cheat and produce greater force. It's not very high, by the way. But that was a practice, so it's okay. So another key point, you've got to be very, very careful that you do not continue pushing the leg down onto the bed, because as you can see, just zero this, if I push onto the bed, that'll give a much higher score, okay, than what he was actually able to produce. So it's important that you stop short of the leg hitting the bed. The other thing that's really important with, as I mentioned yesterday, this is a maximum voluntary contraction, so it is essential that you use your methods of motivation and your psychological methods to ensure that the output that they're giving you is their best output. And you know, your athlete may be tired, it may be at the end of the day, or they may just not want to be there, but you've got to use your skills as a therapist to try to get the maximum output from that athlete. So we tried a lot of different methods in terms of creating competition between the two athletes, or whatever methods we needed to ensure that we were confident that we were getting their maximum output. Okay, so I'll just do that one more time. So we're very picky, Andreas and I, in our positioning. Okay, keep your knees straight and go ahead. Push, 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 push. Okay, and you'll see that I use 2 hands. If you look at Christian's original papers, he's got one hand here and one hand pushing here. Now, you can see quite clearly for someone of my build, there is no chance I'm going to be able to have a good enough force to be able to break him, someone as tall as Robert Young. So there was a lot of discussion recently about females versus males doing this testing, and as I mentioned, our intertester, even though Andreas is a big strong male and I'm quite a small female, our intertester was very good for this test, and this was the method that we used. So we made sure that the pelvis was in the right position first, and then we produced our pressure distally on the leg.
So 3 seconds isometric, and then you use eccentric break, and that's where you'll actually get the highest.
Measure the isometric strength.
No, the measure is
Yeah.
eccentric.
So just to give you a bit of an example, his first one was 136 and second one was 165. So it can vary quite considerably, and that's why it's important to take the maximum rather than the average of the measures. Okay, it has been described in other tests to take the average, but we as a research group feel we want their maximum, and just because maybe one time they switched off and did a poor measure, we don't want that to influence their maximum result. We want to know what's the best that they can produce with this test.
Yeah, another thing in that thing is that if you're not comfortable with the measure, then do it over. Just tell the patient, don't note it down, and just don't be too nice with the patient. Just tell them, all right, you got to do it right, and then take the test again and do the measure.
If you forget to reset the dynamometer, just retest it.
Yeah, exactly. For instance, if he's turning out like that, like Andrea said before, it's it's another muscle testing. All right. So now we'll do the adduction. So we'll straighten that leg. We're testing the right leg now, and it's a similar procedure. Here we're using a bunch of towels here to stabilize the pelvis here, so he has that in a straight position. Still the same straight position here before. Important again that the knee is straight all the time during the testing, and that will also affect the foot position. So the foot position here, also very important, maybe a little bit up here so he doesn't turn, because a lot of the times the players, they would turn the toes downwards, so they'll use the hamstrings.
And bend their knees. This was a very common cheating.
And the knee, So really important to keep the knee straight and the foot horizontal. You take it all the way up to maximal adduction, and then you start the measure here as before with an isometric contraction, and then you push down. So are you ready? You use the mark that you made before, and go ahead. Push, 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 push. Very good. So you stop right before you hit the bed, and you can see his adductors working in here as well. And then you get the measure.
One of the things we didn't mention, because it's so automatic to us, is it's really important that your leg is over the end of the bed, and then you've got less chance of hitting the bed. Okay, so we had our marks here, and we made sure that the patient was, or the athlete was over the end of the bed beyond that mark, and then you've got less chance of hitting the bed. Do it one more time.
Perfect. One more time.
Yeah.
You ready? See what you can get. Straight leg. Up here. Get them all the way up. See you ready? And go ahead. Push, 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 push. There you go. So 3 seconds, and then you start with the eccentric, and he'll reach his maximum measure in the eccentric. Great.
Any questions, anyone?
So these are what we use for the screening, and then we have another measure because we want to develop the test a little bit. So we put him on his back. So when we're thinking about the kicking motion, we want to get to more out of range movement, and we still want to have the eccentric part of the testing. A little bit higher, and we have our abduction measure from before. So if you hold on to the bed. There you go. We'll get the tested leg out into maximal abduction, and you get the feeling here, and you know about how far out he can, because that will vary from patient to patient as well. So this is mainly to look for side-to-side differences, where there can also be differences. So then you take it a little bit in again, so you leave room for the eccentric break. It's important to tell the patient to really contract his abdominals, so he's stable in his pelvic area, and then you use the same measure as you did before. You put your elbow on your hip, so that the whole movement doesn't depend on your upper arm strength, but you're just walking forward like this, and you can use the other hand here. And then we'll do the same test. Are you ready? And go ahead. Push, 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 push. There you go, and then you get another measure. And usually you don't have the towel, so that will make them not slide. No.
And there's a lot of discussion in the literature about how much you should fixate the subject, or whether you should allow them to brace or not brace. And some studies will if you look in the literature, some studies will demonstrate arms crossed so that you're taking out the bracing element, and the idea is that then it's more isolated to the leg. But we felt that it's more reproducible if you actually make them brace as much as they want, and then you're actually getting a reflection of the power output that they can produce with that movement. Because again, we're not testing muscles, we're testing a movement, and there's many different muscles that are contributing to this power output, and a lot of those are how well one can brace the core, etc. And if you remember from Roald's study that particularly when you're testing abduction power output, you're also testing muscles on the other side. You're not just testing that joint. So that's why we chose to allow our subjects to brace as much as they want to. Do you want to do it quickly one more time?
One more time. Ready? Down here.
Without the towel.
And he's going to be sliding. And go ahead. Push, 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 push. There you go. Okay, we need to lock it. All right.
Okay, thanks everyone. Enjoy the rest of your day.
Any questions?